68%. Sit with that number for a moment. 68% of adults over the age of 65 in the United States are currently taking 5 or more prescription medications every single day. Not 1, not 2, 5 or more. And buried inside that statistic is a quieter number that almost nobody is talking about. 1 in 3 adults over 65 already has some degree of kidney damage. Not diagnosed kidney disease necessarily, not kidney failure, just quiet, invisible, measurable damage that showed up on a lab panel and was mentioned briefly, noted in a chart, and then overshadowed by the blood pressure reading and the cholesterol numbers and the 6 other things that needed to be discussed in a 15-minute appointment. Now here is where those two numbers collide. Several of the most commonly prescribed medications in America, drugs that millions of seniors take every single morning without a second thought, are processed almost entirely through the kidneys. And in a body where kidney function has already quietly declined, those medications are not being filtered the way they were designed to be. They are accumulating, they are concentrating, and they are doing damage to the very organ responsible for clearing them. Day after day, quietly, with no pain, no obvious symptoms, no warning until the damage has reached a threshold that shows up on a lab panel that may or may not be ordered at the right time. That is what today is about. Not fear tactics, not telling you to stop your medication. What today is about is giving you the complete picture, the one that a 15-minute appointment was never built to deliver, so that the next conversation you have with your doctor is a real one. My name is Dr. Stephen Parker. I am a physician specializing in cardiovascular health and aging, and in that work, the kidneys come up constantly. Not because I am a kidney specialist, but because the cardiovascular system and the renal system are so deeply interconnected that you cannot talk honestly about one without talking about the other. What the heart pumps, the kidneys filter. What the kidneys cannot clear, the heart eventually pays for. In my work with adults over 65, the pattern I keep seeing is this. A person is prescribed a medication for a completely legitimate reason. Blood pressure, pain, inflammation, diabetes. The prescription is appropriate. The intention is sound. But nobody sat down and explained what that medication does to kidney function over time. Nobody explained that the kidney function test run when the medication was first prescribed may look very different from what that same test shows 3 years later. And nobody put a system in place to monitor the gap between those two numbers. That gap, unmonitored, unexplained, accumulating quietly across years, is what today is about. Stay with me through everything I cover, because what I save for last is the medication class that produces the most dangerous combination of widespread use and insufficient monitoring in seniors over 65. And it is almost certainly represented somewhere in your medicine cabinet right now. Before I walk you through the specific medications, I need you to understand one thing. Because without this foundation, the rest of what I say will feel like isolated warnings rather than a connected picture. I call it the silent filter failure. Here is what that means. Your kidneys filter approximately 200 liters of blood every single day. Every medication you take, every pill, every capsule, every tablet, eventually makes its way into that filtration system. The kidneys identify what the body needs to keep and what needs to be eliminated. They concentrate waste products and excess compounds into urine and clear them from the bloodstream. When you are younger and your kidneys are operating at full capacity, this process is remarkably efficient. Medications move through, do their job, and get cleared. The system works. After 65, 3 things change that system fundamentally. First, GFR declines. GFR stands for glomerular filtration rate, the measure of how efficiently your kidneys are filtering blood per minute. In a healthy 30-year-old, GFR typically runs between 100 and 120. By age 70, even in a person with no diagnosed kidney disease, GFR has commonly declined to somewhere between 60 and 75. That is not kidney disease by clinical definition, but it represents a filtration system operating at 60 to 75% of its original capacity. Medications dosed for a full capacity filtration system are now being processed by a system running significantly below that. Second, the warning system is broken. Here is the part that makes kidney decline specifically dangerous. The kidneys have no pain receptors. They send no distress signals. A kidney operating at 50% capacity feels identical from the inside to one operating at 90%. There is no ache, no obvious symptom, no alarm. By the time symptoms appear, swelling in the legs, chronic fatigue that sleep cannot fix, changes in urination, mental fogginess, the damage has typically progressed well beyond early stage. Third, standard lab panels miss the early window. The standard creatinine test included in most routine lab panels is a relatively late marker of kidney decline. It does not begin rising meaningfully until kidney function has already dropped below approximately 50% of normal. The more sensitive early marker, cystatin C, is rarely ordered in routine senior care, and eGFR, which estimates filtration rate, is calculated but frequently not discussed unless it drops into a range that triggers an automatic specialist referral. The early window, the period when medication adjustments and monitoring could prevent significant damage, passes quietly, without fanfare, while the prescription gets refilled month after month. Keep the silent filter failure in mind through every medication we discuss today, because the danger in each case is not that the medication is inherently harmful. The danger is what the medication does inside a filtration system that is quietly changed without anyone recalibrating the dose, the monitoring frequency, or the risk conversation accordingly. Medication number 5. Proton pump inhibitors, PPIs. Let me start with the one that feels the least threatening, because that is exactly what makes it worth starting with. Proton pump inhibitors, PPIs. You know them by their brand names: Prilosec, Nexium, Protonix, Prevacid. They are prescribed for acid reflux, heartburn, GERD, stomach ulcers, and as stomach protection alongside other medications that can irritate the digestive lining. They are also available over the counter, which means millions of seniors are taking them not just because a doctor prescribed them, but because they picked them up at the pharmacy themselves and have been taking them daily for years. Here is the kidney connection that most people have never been told. A large-scale study published in the Journal of the American Medical Association, Internal Medicine, analyzing data from more than 170,000 patients, found that PPI users had a 28% higher risk of developing chronic kidney disease compared to non-users. A subsequent study following PPI users over 5 years found that approximately 15% developed chronic kidney disease during the observation period. The proposed mechanism involves a condition called acute interstitial nephritis, an inflammatory reaction in the kidney tissue that can be triggered by PPI use and that, in its chronic low-grade form, may not produce obvious symptoms while quietly progressing. But here is the second mechanism that is equally important and less discussed. Long-term PPI use significantly reduces magnesium absorption in the gut. And magnesium is not simply a supplement. It is a mineral that plays a direct regulatory role in kidney function, blood pressure management, and cardiovascular rhythm. Magnesium deficiency in seniors is associated with accelerated kidney decline, arterial stiffness, and increased risk of cardiac arrhythmia. So the PPI prescribed to protect the stomach is simultaneously reducing absorption of a mineral the kidneys and heart depend on. I want to tell you about Clarence. Clarence is 72 years old, a retired factory supervisor from Akron, Ohio. He had been taking omeprazole, a PPI, daily for 7 years. Originally prescribed for acid reflux. Over time, it became simply part of the morning routine. When his routine lab panel flagged an eGFR of 54, indicating moderate kidney function decline, his primary care doctor noted it in the chart and scheduled a follow-up in 6 months. Nobody asked about the omeprazole. When Clarence came to me and we reviewed his full medication and supplement history, we identified the PPI as a potential contributing factor. We worked with his gastroenterologist to taper and discontinue the omeprazole, replacing it with dietary modifications and an H2 blocker, a different and generally kidney-friendlier acid management approach used only as needed. At his 6-month follow-up, his eGFR had stabilized and his magnesium levels had returned to normal range. Clarence's words when he understood the connection. 7 years. The pill I was taking for my stomach was quietly affecting my kidneys, and nobody thought to ask about it. What to do instead? If you have been on a PPI for more than 8 weeks, ask your doctor 2 things. First, is this medication still necessary, or can we discuss stepping down or stopping it? Studies show that a significant percentage of long-term PPI users no longer have the original indication that prompted the prescription. Second, has my magnesium level been checked recently? That is a simple addition to any standard blood panel. Medication. Number 4. Common diabetes medications. I want to be extremely precise here because this medication has an excellent safety record when used appropriately, and the nuance matters. Metformin is one of the most prescribed medications in the world for type 2 diabetes. It is effective, well-studied, and generally well-tolerated. For most adults with normal to mildly reduced kidney function, it remains a first-line treatment with a strong evidence base. The kidney concern with metformin is specific, serious, and almost never explained clearly to patients. When kidney function declines below a certain threshold, specifically an eGFR below approximately 30 to 45, depending on the guideline, metformin begins accumulating in the body at levels it was not designed to reach. And at elevated concentrations, metformin can trigger a rare but potentially fatal condition called lactic acidosis, a dangerous buildup of lactic acid in the bloodstream that can cause severe muscle pain, difficulty breathing, stomach pain, and in serious cases, organ failure. The FDA updated its metformin prescribing guidance specifically to address this risk in patients with reduced kidney function. Here is the problem. Kidney function declines gradually and silently. Remember the silent filter failure. A patient who was appropriately prescribed metformin 4 years ago when their eGFR was 68 may now have an eGFR of 42. The prescription has been refilled automatically, the dose has not been adjusted, and nobody has connected the declining kidney number on the lab panel to the metformin prescription that has been running on autopilot. I want to tell you about Sylvia. Sylvia is 74 years old, a retired bank teller from Springfield, Illinois. She had been on metformin for 11 years. Well-managed, stable blood sugar, good compliance. Her eGFR had been drifting downward for 3 years, documented on every annual lab panel, but had never triggered a formal medication review. When her eGFR reached 38, her new physician finally flagged the metformin dose as requiring urgent reassessment. Sylvia had been experiencing unexplained muscle fatigue and occasional nausea for the better part of a year. Both had been attributed to age. A medication adjustment and transition to a kidney-friendlier diabetes management approach resolved both symptoms within 6 weeks. Sylvia's words. My blood sugar was managed. Nobody told me that what was managing it was becoming a problem for something else. What to do instead? If you take metformin, ask your doctor what your current eGFR is and whether your metformin dose has been reviewed in light of that number within the past year. This is not a complicated conversation. It is a specific, targeted question that takes 30 seconds to ask and could matter enormously. Medication number 3, NSAIDs. Here it is, the one I told you about at the beginning, the one that will genuinely stop you, the one with the highest combination of universal use and insufficient awareness about kidney risk in older adults. NSAIDs, non-steroidal anti-inflammatory drugs, ibuprofen, Advil, Motrin, naproxen, Aleve, not exotic prescription drugs, not medications with obvious danger labels, the pills sitting in the bathroom cabinet, the kitchen drawer, the purse, the nightstand, the ones reached for when a knee aches, when a back tightens up, when arthritis makes a morning difficult, when a headache needs addressing, the ones that say on the package, for pain relief, trusted for decades, available without a prescription to anyone who walks into any pharmacy in America. And they are among the most kidney-damaging substances a senior can take regularly. Here is the mechanism, and I want you to understand this clearly because it explains why the damage happens and why it happens silently. Your kidneys receive approximately 20 to 25% of your heart's total blood output every minute. That blood flow is maintained partly through the action of compounds called prostaglandins, locally produced molecules that keep the blood vessels feeding the kidneys dilated and responsive. NSAIDs work by blocking prostaglandin production. That is how they reduce pain and inflammation throughout the body. But that same blocking action reduces prostaglandin activity in the kidneys. And when prostaglandins in the kidneys are suppressed, the blood vessels feeding the kidney tissue constrict. Blood flow to the kidneys drops. In a younger person with healthy, elastic kidney vasculature and full GFR capacity, the body compensates for this constriction effectively. The kidneys weather the temporary reduction in blood flow without measurable lasting damage. In an adult over 65 whose kidney vasculature has already stiffened, whose GFR is already operating below its original capacity, and whose compensatory mechanisms have slowed, that same constriction is not compensated effectively. Blood flow to the kidney tissue drops to a level that causes measurable cellular damage. Repeated across days, weeks, and months of regular use, that damage accumulates, quietly, without pain, without warning. The American Geriatric Society explicitly lists NSAIDs as potentially inappropriate medications for older adults, included in what is called the Beers criteria, a regularly updated list of medications whose risks in older adults frequently outweigh their benefits. But that designation exists in clinical literature. It does not appear on the ibuprofen bottle at the pharmacy. And here is the compounding risk that makes this even more serious. Many seniors who take ibuprofen or naproxen regularly are also on blood pressure medication. Several common blood pressure drug classes, ACE inhibitors and ARBs specifically, also affect kidney blood flow through a different mechanism. When an NSAID and an ACE inhibitor or ARB are taken simultaneously, their combined effect on kidney circulation is significantly greater than either alone. This combination has a name in nephrology. It is called the triple whammy when a diuretic is added, and it is one of the most well-documented causes of acute kidney injury in older adults. 3 medications, each prescribed or taken for a legitimate reason, each individually managed. Nobody looking at all 3 together and explaining what happens to kidney blood flow when they run simultaneously. I want to tell you about Arthur. Arthur is 77 years old, a retired carpenter from Tucson, Arizona. Hands built things his entire life, and hands built for an entire career of physical work carry the arthritis to show for it. Arthur's knees and lower back had been his daily companions for years. His solution, the one that worked, the one that let him keep moving, was ibuprofen. Not prescribed, purchased. 2 tablets in the morning when the stiffness was bad, sometimes 2 more in the afternoon. Arthur was also on lisinopril for blood pressure and hydrochlorothiazide, a diuretic, for fluid retention. He had the triple whammy running every single day. And nobody knew because the ibuprofen was never on his prescription list. It was over the counter. It was not something anyone thought to ask about. When Arthur came in after an emergency room visit for what had been diagnosed as acute kidney injury, his creatinine had spiked to nearly 3 times its baseline in 10 days. The ibuprofen connection was identified in that emergency setting. Arthur had never been told. Not once in years of annual physicals had anyone asked, "Are you taking any over-the-counter pain medication regularly?" Arthur's words when he was discharged and we sat down together, "It was just Advil. You can buy it anywhere. I never thought I needed to mention it to a doctor." That sentence, that reasonable, understandable assumption, is being repeated in homes across this country every single day. What to do instead? For arthritis and chronic joint pain in adults over 65, the alternatives with meaningfully better kidney safety profiles include topical diclofenac gel, applied directly to the painful joint, absorbed locally with minimal systemic kidney exposure. Acetaminophen, Tylenol, for moderate pain, used at appropriate doses, is significantly safer for kidneys than NSAIDs in older adults, though it carries its own liver considerations. Physical therapy and targeted exercise programs for joint pain have outcome data that rivals medication in chronic arthritis management. And the single most important thing you can do right now: tell your doctor every over-the-counter medication and supplement you take regularly. Not just the prescriptions, everything. Medication number 2. Certain antibiotics. This one surprises people in a different way than the others on this list, because antibiotics feel temporary. You take a course, you finish it, you move on. They do not feel like the kind of medication that accumulates risk over time. But for a specific class of antibiotics, and in the context of how frequently some seniors require antibiotic treatment for recurring urinary tract infections, respiratory infections, and skin infections, the kidney picture is more concerning than most people realize. Fluoroquinolone antibiotics, ciprofloxacin, levofloxacin, moxifloxacin, are among the most frequently prescribed antibiotic classes in older adults. They are broad-spectrum, effective, and convenient as oral medications for a wide range of infections. They are also nephrotoxic, capable of causing kidney damage. And the FDA has issued multiple safety communications specifically warning about serious adverse effects of fluoroquinolones, including kidney injury, that are more pronounced in older adults with existing kidney function decline. Here is the specific mechanism. Fluoroquinolones are eliminated almost entirely through the kidneys. In a senior whose GFR has declined, these antibiotics clear more slowly. They reach higher peak concentrations in the bloodstream and in kidney tissue than they would in a person with full filtration capacity. And at elevated concentrations, they can trigger inflammatory and toxic reactions in the tubular cells of the kidney, the cells responsible for the fine-tuned filtration work. The risk is compounded by frequency. A senior who has 3 or 4 urinary tract infections per year, not uncommon in this population, and is treated with a fluoroquinolone each time, is exposing kidney tissue to this nephrotoxic load repeatedly. Each course may individually fall within what appears to be safe dosing. Cumulatively, across years and repeated exposures, the damage adds up. I want to tell you about Miriam, Miriam is 79 years old, a retired seamstress from Albuquerque, New Mexico. She had struggled with recurrent urinary tract infections for several years, a common challenge in women her age, and had been treated with ciprofloxacin on 4 separate occasions over an 18-month period. Each course was appropriately prescribed for a genuine infection. Each course was completed. But nobody was tracking the cumulative kidney exposure across those 4 courses. Nobody was checking her eGFR between infections to see what the repeated antibiotic exposures were doing to her baseline filtration function. When Miriam's eGFR was formally measured 18 months into this pattern, it had declined from 61 to 44, a drop significant enough to reclassify her kidney function from mildly to moderately reduced. And that reclassification had implications not just for antibiotic choice going forward, but for the dosing of every other medication she was on. Miriam's words: "I finished every course exactly as directed. I did everything right. Nobody told me that doing everything right 4 times in a row could still add up to something wrong." What to do instead? If you experience recurrent infections requiring repeated antibiotic treatment, ask your doctor 2 things. First, is there an alternative antibiotic class with a better kidney safety profile for my current eGFR level? Second, can we check my kidney function before and after antibiotic courses given the frequency of my infections? Those questions are not difficult. They are exactly the questions a physician managing your care longitudinally should be asking anyway. Medication. Number 1. Certain blood pressure medications. And here is the final one, the one that requires the most precision because it involves a genuine paradox. ACE inhibitors and ARBS, angiotensin converting enzyme inhibitors and angiotensin receptor blockers, are among the most prescribed blood pressure medications in adults over 65. Lisinopril, Ramipril, Losartan, Valsartan. You almost certainly recognize at least one of those names. And here is the paradox. These medications are actually kidney protective in many contexts. For patients with diabetic kidney disease or certain forms of kidney damage, ACE inhibitors and ARBS are specifically prescribed because they reduce pressure within the kidney's filtration units and slow the progression of existing kidney damage. So why are they on this list? Because protective and harmless are not the same thing. And because the kidney protection these medications offer in the right patient at the right dose with the right monitoring can become kidney harm in the wrong monitoring environment. Specifically, in seniors whose kidney function is declining and whose medication is being managed on autopilot without the monitoring frequency the drug requires. Here is what happens. ACE inhibitors and ARBs work partly by dilating the blood vessels that exit the kidney's filtration units, the efferent arterioles. This dilation reduces the pressure inside the filtration units, which is beneficial in protecting against certain types of kidney damage over time. But when kidney function has declined significantly, when GFR drops below certain thresholds, that same dilation of efferent arterioles can reduce filtration pressure to a point where the kidney can no longer maintain adequate filtration. The very mechanism that protects kidneys at one stage of function can compromise filtration at another. Additionally, ACE inhibitors and ARBs raise potassium levels. In a person with good kidney function, this potassium elevation is managed efficiently. In a person with significantly reduced kidney function, potassium can accumulate to levels that affect cardiac rhythm, a condition called hyperkalemia that can cause dangerous and potentially fatal heart arrhythmias. The monitoring that these medications require, regular eGFR checks, potassium levels, creatinine monitoring, is well established in clinical guidelines. But in the reality of senior care, where multiple conditions are being managed simultaneously in brief appointments, that monitoring frequently falls behind the schedule it requires. I want to tell you about Vincent. Vincent is 71 years old, a retired school bus driver from Baltimore, Maryland. He had been on lisinopril for blood pressure for 6 years, well controlled, no complaints, refill after refill. His potassium and kidney function had not been formally checked in 14 months when he came to me after his wife noticed he had been experiencing irregular heartbeat episodes and unusual fatigue for several weeks. His potassium level was critically elevated. His eGFR had dropped to 34. His lisinopril dose, appropriate when his kidneys were functioning at a higher level, was now producing potassium accumulation his kidneys could no longer clear efficiently. The cardiac arrhythmia his wife noticed was the sound of that accumulated potassium affecting his heart's electrical system. Vincent's words after we stabilized his potassium and adjusted his medication. 6 years on the same pill. Nobody told me that the same pill at the same dose could become a different risk as my kidneys changed. What to do instead? If you take an ACE inhibitor, or ARB for blood pressure, ask your doctor one direct question at your next appointment. When was the last time my kidney function and potassium level were both checked together? If the answer is more than 6 months ago, or if the answer is uncertain, that is the conversation to have, right then, in that appointment, not at the next one. Here is what I want you to walk out of today with. Not just awareness, a specific plan. Step 1. Find out your current eGFR. This number should be on your most recent lab results. It is reported alongside your creatinine level. If you do not have a copy of your recent labs, call your doctor's office and ask for your most recent comprehensive metabolic panel results. Ask specifically what your eGFR number is. If it is above 60, your kidneys are in the mildly reduced to normal range. If it is between 45 and 60, moderately mildly reduced. Medication review is important. If it is below 45, moderately reduced. Every medication you take should be formally reviewed against that number. Step 2. Make a complete medication list. Every prescription. Every over-the-counter medication taken more than occasionally. Every supplement. Write it down. All of it. This list is the document that changes your next appointment from a routine visit into a productive conversation. Step 3. Bring these 3 questions to your next appointment. Question 1. Given my current eGFR, are all of my current medications dosed appropriately for my kidney function level? This question often surprises physicians because it is specific and informed. A good physician will welcome it. It takes the conversation from general to precise immediately. Question 2. Which of my medications require regular kidney function monitoring? And are we monitoring on the schedule those medications actually require? Monitoring schedules exist for a reason. Asking whether yours is being followed is not combative. It is exactly what a protected patient does. Question 3. Am I taking any combination of medications that together create a higher kidney risk than any single medication alone? Combination risks, like the triple whammy, are almost never discussed proactively. Asking the question puts it on the table. Any physician genuinely committed to your long-term health will not be bothered by those questions. They will be glad you asked them. There is something I want you to hold on to after this video ends. The medications we talked about today were not prescribed carelessly. The doctors who prescribed them were not being negligent. In most cases, the prescriptions were appropriate at the time they were written for the kidney function that existed at that moment. The problem is not bad medicine. The problem is medicine that does not automatically update itself as your body changes. Your kidneys at 72 are not your kidneys at 62. Your filtration capacity at 75 is not what it was at 65. and a medication dose calibrated for one version of your kidney function may need to be reconsidered for another. That recalibration does not happen automatically. It does not happen at every appointment. It happens when you walk in with your medication list, your EGFR number, and 3 specific questions written on a note card in your pocket. That is not a difficult patient. That is a protected one. In the next 24 hours, I want you to do one thing. Find your most recent lab results. Look for the number labeled EGFR. Write it down. Put it in your phone. Bring it to your next appointment alongside the name of every medication and supplement you take daily. That combination, your EGFR and your complete medication list in the same conversation, is the beginning of a kidney protection plan that no pill can replace. There is someone in your life right now who takes a daily prescription and has never once been told what that medication does to kidney function over time. A spouse, a sibling, a parent whose medications you help manage. This video was made for that person too, and you can get it to them in 30 seconds. Write the number of prescription medications you take every day. Just the number, no names needed. I read every comment on this channel, and I want to see those numbers, because what shows up in the comments section will tell a story about what seniors in this country are actually managing every single day. And that story matters. If what we covered today changed how you think about your medications and your kidney health, subscribe to this channel right now. Because next week, I am covering the other side of this conversation. We talked today about what your medications may be doing to your kidneys silently. Next week, I am covering the specific kidney markers that your standard lab panel is almost certainly missing. The early warning numbers that appear in the blood work before creatinine rises, before EGFR drops to a level that triggers concern, when there is still a meaningful window to change the trajectory. Most doctors do not order these markers routinely. Most seniors have never heard of them. And most of the damage that eventually becomes a diagnosis could have been caught in that earlier window if someone had known to look. That video is the one that connects everything we discussed today to an actual early detection strategy. And you will want to have seen this one before you watch it. I am Dr. Stephen Parker. Take care of yourselves. Take care of your kidneys. I will see you next week.